There are more students to come. Okay, sure, sure. No problem. Sure, sure, sure. Okay. Well, I am told that they have started the recording and I should start. So, since they say that the recording has started, let's start the lecture. I go a little bit slower at the beginning, hoping that other students will come in time for the more important things. So today we are going to talk about the clinical approach to hypertension. And I want to tell you, I am actually the course director of the kidney and urinary tract for the University of Florida. So I have to know about USMLE. I have to know what is needed for the kidney and urinary tract questions and all those. One thing that you want not to miss is that you have 1 hour on hypertension here, but the genetic causes of hypertension is something that for some reason USML is very big on. You're talking about Liddle syndrome, other weird syndromes that I have never seen. Probably the pediatric nephrologists see them because they are genetic most of the time. But these are things that they want us to know. Okay. So what this is a good introduction for hopefully for you for hypertension in general. You need to be very, I would say, strong on the genetic causes and I would say all those syndromes that you probably have seen. There are some tables, they say the different things between them. This one, the potassium up, down, renin up, down, and all those. You need to know them very well. So this is one of the medical students, first year medical students. For us, she wrote or he wrote, I don't know. Day by day, I'm being. You see, I am so fan of kidney. I hope that by the end of the week, you will feel the same way. That is my way of advertising for my own organ. These are the learning objectives. You are going to read them on your own. Let's start with a case, as always. Mr. Paul Smith. He's our 64-year-old gentleman who has no past medical history. He's a retired teacher, lives with his wife, Sarah. He feels well and regularly plays golf with his friends 3 times a week. Very good. He's referred to you for evaluation of blood pressure. Remember, we had another patient came to you for evaluation of renal function, evaluation of blood pressure. Is this a good thing per se? I think it is because awareness of existence of something is the first day or first step in trying to treat that. And why do I say this? Because I have looked at this table. This table is a busy table. If we want to clean it, we remove those numbers, and here's what you see. What you see here is that, and this is an older one, but the concept has not changed. We think about the concept. Obviously, the numbers are not important. I myself have not memorized these numbers. The numbers are not important. Think about the concept. The concept is that around 70% of the people who have hypertension are even aware of the fact that they have hypertension. So 30% don't even know they have hypertension, and 60% only, 59% get treatment, and worse even, 34% are well controlled. Think about it. Many people are not aware that they have it. Some of them that they are aware, they do not get the treatment. Some of them that get the treatment are not even under good control. The point is that, and the last part is you and me. This 34 is us because the patient has come for treatment. We have failed the patient. The patient is not well controlled despite the fact that he or she is coming to us for treatment. The point is that with hypertension as a rule, we are not doing that well in the society. And it is not necessarily the hypertension itself, because hypertension and diabetes are very prevalent. We know more about them. Maybe it's pretty much the same for another. For hyperkalemia, we might not be that good either, but we don't know about it. For this, we know about it. There are many numbers here. So that's number one. If it turns out that our Mr. Smith, wasn't he Turner? I change names sometimes in between the slides, I forget. So let's say he's Mr. Smith. Mr. Smith has hypertension. Should we consider treating him? One thing that you start learning, this is now a little bit more of a science. It's more than just what you see in New York Times. So I have hypertension. Who says that if I am treated, I do better? You need to have numbers. The things that are common sense are not necessarily true. For many, many years, we treated patients with chronic kidney disease for their anemia. Just recently, we realized that we have been increasing their mortality by treating them. It has been a mechanism of defense. We should have left them alone. Yet, we thought it's common sense. He has chronic kidney disease. He's anemic. Let's treat him. We treated him. His mortality went up. So keep that in mind. The things that we hear on I would say, in the newspapers, on the news, and all those, you and I, we need to have another level of discussion. If it turns out, is he at risk? Basically, I'm asking, if a patient has hypertension, is he at risk of something? Your blood pressure is higher than mine. So what? Your eye is brown, mine is green. So what? Right? So is it the difference, or it is really a major risk factor? And we say it may be a risk factor. Why do I say that? What you see here, and it is a busy slide, the concept is important. Don't get into the numbers. These numbers have changed probably. The concept is, look, this is the systolic blood pressure. It tells you the higher the systolic blood pressure, the higher the mortality from ischemic heart disease or coronary heart disease. And it is in different age ranges. Technically, it tells you in any age range, the higher my systolic blood pressure, the higher my mortality. It doesn't talk about causality. Remember, it just tells you if I have higher blood pressure, it is associated with mortality. Is it the cause of it or not? That's a different story, right? Keep that in mind. For diastolic, it's the same concept. I'm not going to stop that. This is diastolic, this is systolic. It tells you another thing also. This is, the black is 80 to 90 years up here. You see, with that also, as the blood pressure goes up, the mortality goes up. So don't say, oh, he's 82, he's so cute, don't treat him. Doesn't matter. 82, 85, 89 needs to be treated if you want to think. Actually, let me correct myself. Is associated with mortality for that age range. Whether we need to treat him or not, we will see it later. But for now, we know that even in higher age range, increase in systolic blood pressure associated with higher mortality, higher death. Okay, we said that. And not only that, for a stroke, it's the same thing. Everything that you call cardiovascular disease, which includes stroke and heart failure and ischemic heart disease, it's the same concept. The same concept is here. Again, don't go into the numbers. I don't know the numbers myself. You don't have to know. The concept is there, however. The higher, the more association. Okay. So now we know about the association. Now to the next level. So you tell me that if my blood pressure is higher, this is associated with higher mortality. But who says that this is a cause? Who says that if I treat this, the mortality will go down? You need to show me numbers. And now for hypertension, we have the numbers. For many things, we don't. Any benefit free treatment of hypertension now? Here we are. Look, the black curve is when somebody's blood pressure is in general. Okay. This is the distribution of blood pressure let's say in a community. If you intervene, if you give them medicine to treat their blood pressure, right? You push the blood pressure to the left, meaning that they have lower blood pressures. Here is the blood pressure in on the x-axis here, right? If I treat them, so this is before intervention, the black line, and the red line is after intervention. I improve their blood pressure by giving them medicine. Treating hypertension is associated with reduction in mortality. This is what we needed to be convinced that we should treat our patients. All other things I told you before were the interaction. The main thing that convinces you, hey, if I want to bring down the mortality of Mr. Smith, I need to give him 5 milligrams of amlodipine, comes from this diagram. If we push the blood pressure to the left, if we reduce the blood pressure, stroke comes down, coronary heart disease comes down, in general, cardiovascular disease comes down. Again and again and again, the numbers are not important, the concept is important. But if you ask me, among all the cardiovascular diseases, which one has a tighter association with blood pressure? Do you know which one is the one? Tighter association. We have, cardiovascular disease. You can say peripheral vascular disease is cardiovascular disease. Coronary heart disease is, heart failure is, stroke is. All of them are. Which one is tighter? All of them are associated. Which one is tighter? Stroke. Stroke is the main one. So if you treat somebody, all cardiovascular disease outcomes will improve, especially the stroke. That's why if I have a patient who has a history of a stroke, comes, the blood pressure is borderline, I'm not going to mess around. I will be aggressive with treating that patient. But if I have a patient with, let's say, peripheral vascular disease, comes with blood pressure on the fence, I start by lifestyle, do this, do that. Before I know that, now I need to treat the patient. So being more aggressive would be for the stroke patients. Reduction, lower. Okay. This is what the important part is. Reduction in blood pressure lowers, is not an association, it's a causality. Lowers the mortality from stroke. And okay. So the benefits are coming from hypertension. So the answer has been yes. This is the question that you had before, and now the answer, you know it, it is yes. So now that we know blood pressure needs to be treated, the next stop would be, so Amir, how do I even know if a patient has hypertension for the next step to treat it? There are at least three ways of checking the blood pressure or measuring blood pressure to make the diagnosis. One is the home. We ask the patient at home to check their blood pressure with their own cough, and they bring us a log. Office blood pressure, they don't have any cough or they don't check blood pressures at home, they show in our offices. And you know that any office in US, when you go, they're supposed to check your blood pressure. You go to dental office, they check your blood pressure. You go to primary care, ophthalmology, everybody has to check your vital signs. That's a rule. So everybody will check their blood pressure in the office. The third one is ABPM, ambulatory blood pressure monitoring. We are going to talk about it in a second. Office blood pressure, is it always reliable? That's a good one. The nurse takes it, they know what to do. She knows it. It is not always reliable. It's a one time deal. It's about like urine sodium. You check it at 6 p.m., it might be different from 9 p.m. It's good to have an idea, but it is not enough, right? So we will see. If you look at the office hypertension and the blood pressures that patient takes at home, I tell them at home, take it a few times a week, write it down and bring it for me. The important thing is I ask them to check it different times of the day. 8 a.m., 9 p.m., 4 p.m., 11 a.m. I want to know what the blood pressure is over a day rather than each time at 10 a.m. Okay. So there are four different possibilities. The patient might have no hypertension based on the office or the home. This is the good group, good outcome. Hopefully, all of you. True hypertension is somebody who Both in the office, you see, has high blood pressure. At home, also, the log of blood pressure that brings has high blood pressure. This group is a little bit tricky, right? They come to your office, they are anxious or whatever, they have high blood pressure, but when you check their blood pressures at home, they bring a log, they didn't have it. So positive in the office, but negative at home. White coat hypertension is okay, right? That's a good thing. It is just a one time increase in the office. Would you agree with me? The outcome is pretty much the same as normal blood pressure. Would you agree? Don't agree. We thought this is the case, but there should be no reason that somebody goes to the office and the blood pressure is high. Their outcome is not as bad as somebody with true hypertension, but not as good as somebody with normal blood pressure. It's a sign of endothelial dysfunction that I go to Dr. Smith's office and my blood pressure is a little bit higher. Keep that in mind. This was the myth. We thought that white coat hypertension, oh, that's fine. Oh, that's good. No, it's not good. Last one is the worst one, masked hypertension. So when they come to the office, their blood pressures are good. We are happy with them. They are happy. No medicine, no nothing. But when we give them a blood pressure log at home, they bring us a log. It has always been high. Don't tell me why. We don't know. But masked hypertension is the one that has more tendency to be hidden, not to be treated. Would you agree? Yeah. Okay. If you think about masked hypertension, that would have been uh, diagnosed if we had a way at home to check the blood pressure very regularly. Either the patient is good and checks blood pressure often and writes it down, or even better, if we use what we call ambulatory blood pressure monitoring. Bless your heart. Okay. So, what are I told you the other time, I hated the professors when they gave me a big list in medical school, pretending that they knew everything in that and not telling me which one I need to know. So, I don't do that to you. Each time I give you a big list, I will tell you these are the things that you need to remember. So, if I ask you, what are the main indications to check ABPM? Suspected white coat, meaning that I think that this patient only in the office or he or she tells you that I go for ambulatory blood pressure monitoring. Apparent drug resistance. I am giving this patient medicine after medicine after medicine. The blood pressure doesn't budge. So that's something that I want to check. And masked hypertension, the most important one. The blood pressure is good, but I wonder, this patient's blood pressure is perfect. Yet I did an echo of the heart and I see major left ventricular hypertrophy, LVH. What does LVH tells you? LVH tells you that there is a lot of pressure out there, so the heart needs to just go really hard to push the blood outside of the heart. That's basically it. There are two occasions that the heart has LVH, two main occasions. One is when you have hypertension, so the heart has to just push the blood out against the major blood pressure at long run, 5 years, 10 years, right? Second is that if I have aortic stenosis, there's not a lot of room for the blood to go out, so it has to push hard. Over time, it gets hypertrophy. Does that make sense? So if I see a patient has normal blood pressure, on echo I see LVH. The aortic valve is normal. I will suspect masked hypertension. This patient has hypertension that has not been diagnosed. Ambulatory blood pressure monitoring, ABPM. So what is ABPM? You say, how you told me what's the indication, but I don't even know what it is. This is what it is. I give the patient a cuff. It has also a box in it that can have a memory and can just keep the numbers here. So it checks the blood pressure periodically and keeps the numbers in the memory. That's all it does. So we put it on the arm of the patient and The box goes on the waist. Okay. Then we ask them to go and do whatever they normally do. They go shopping, they go to work, they go playing, whatever they do normally. And all this time, the ABPM is periodically checking their blood pressure and putting in the memory. For example, I can put during the day, check it every hour. During the night, check it every 2 hours. We can set it when we want. The patient will hate you if you put it every half an hour during the night. It just goes up, wakes up, goes back to sleep. So basically, we have a good blood pressure log of the day and the night. That's the difference between when I ask the patient to check the blood pressure at home. Because when they check it at home, it's only when they are awake. This one does it when they are sleeping as well, right? So it's better. And this is what it gives me. How can it be any better? 11 a.m., this was the systolic blood pressure, this was the diastolic blood pressure. 1 p.m., 5, go. And then during the night, something hopefully has drawn your attention. Do you see it's here, 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 here? Look around 9 p.m. Do you see it coming? This is the circadian rhythm of blood pressure. You and I, we have a circadian rhythm in many things in our body, including the blood pressure. Our blood pressure has to, in normal people, has to dip during the night. What we call dipping is good. We say dippers versus non-dippers to the extent that if two people have normal blood pressure all the time, one is dipper, one is not dipper, the dipper will have a better outcome. Does that make sense? If you don't dip during the night, it's a sign of endothelial dysfunction. It might not be clinically overt, but at long run, it will affect your outcome. So this is basically ABPM, ambulatory blood pressure monitoring. Should we do a question? What is MEXAP? Medical Knowledge Self-Assessment Program. Basically, those who have finished their medical schools, who have gone to 3 years of internal medicine residency, at the end of their residency, they take these questions in preparation for internal medicine boards. So if you can answer these questions, it means that your level of knowledge is at the end of the internal medicine residency, not even medical school. 54-year-old lady evaluated for abnormal EKG at a local health screening fair. He has no cardiovascular symptoms. On physical exam, blood pressure is 136/80. We'll see if it is normal or not, but I think common knowledge is that it's not bad. Vital signs are normal. Lab studies are good. EKG them. I think I told you one of the questions already. She has LVH with normal blood pressure. A follow-up echo confirms symmetric LVH without evidence of aortic valve disease. Which of the following is the most appropriate next step in the management? 24-hour ABPM, cardiac MRI chlorthalidone, which is a thiazide diuretic, and coronary artery calcium score. Which one would you go for? Would you go for A? I think it's reasonable. So this patient has normal blood pressure, but the echo tells us blood pressure probably is not normal all the time. That's what the echo is telling us. Has LVH, which has been confirmed on a second echo without aortic disease. Tells you probably this patient has blood pressure that you haven't figured it out. ABPM would be the way to go because it was one of those indications I told you, masked hypertension. Okay, very, very good. You see how good you are? This is for board preparation for the internal medicine, and you can answer them or I can be close to it even. You check Mr. Smith's blood pressure, it is 165/100. He checks his blood pressures once in a while at home and at the grocery stores and says this is a typical blood pressure for him. So you know that this is not a one-time thing. He says that this is my usual blood pressure. Okay. Does Mr. Smith have hypertension? How do we make the diagnosis of hypertension? What are the cutoffs basically? Clinical approach to hypertension would be this way. Three steps. We first need to make a diagnosis, coming with those tools that I told you: home blood pressure, office blood pressure, ABPM. Those tools you use to make the diagnosis. Step two is assessing possible causes. It's not always primary. There might be some cause for hypertension. We are going to talk about it in a second. And the third would be management. First, how do I make the diagnosis? For diagnosis, basically, I'm asking you, if I give you some numbers, what's the cutoff to say this is hypertensive, this is not hypertensive? Different guidelines over the years have come up with different numbers. To this date, we haven't agreed on. American Society of Nephrology says something. American College of Cardiology says something. JNC is different. JNC is kind of a for practitioners, general practitioners, everybody. It is more, I guess, a bigger umbrella. So I use that as the point of reference. Don't be too much involved in the numbers because it will change over time. Every couple years, there is a new entity coming, new data, new cutoff. So for now, the latest one is JNC 8. It is called Joint National Committee. Well, we call it JNC 8. So JNC 1, 2, 3, over the years, every few years, they come up with the new guidelines. Currently, they say look at age, diabetes, and CKD. I told you that introduction, so you don't come and tell me American College of Cardiology says 130 over 80. I know that. But JNCA, we go with one. We have to pick one, and we stick with that one for the course. For the course at the University of Florida, I have picked JNC8 because I think that it is more widespread, acceptable, but I will even tell you what my suggestion is or what the nephrologists prefer. But we need to know the national one first. So it is determined by three different factors: age, presence or absence of diabetes, presence or absence of kidney disease. This is what it says. First, it is wow, another big diagram is coming up. But if you look into it, it is all actually very, very, very easy. Basically, it tells you, let me go back. Everybody's 140 over 90 or less. It should be 140 over 90 or less, except for the older people over 60 who do not have diabetes, who do not have kidney disease. If I have somebody over the age of 60 who does not have CKD, who does not have diabetes, my goal, my blood pressure cutoff would be 150 over 90. The rest of the people, 140 over 90. So it's kind of easy when you look at the diagram. So target blood pressure less than 140 over 90, except for those more than 60 without diabetes or CKD. For them, it is 150 over 90. Just a side note for the fun of it. In pregnant people, the cutoff is different. Do you think for pregnant people will give lower blood pressure or higher blood pressure in terms of cutoffs? Higher. Exactly. Why? Because that blood pressure at long run is bad. We agree on that. 10 years, 20 years. But during those 9 months, this blood pressure is pushing blood to the placenta and going to the baby. So actually for them, what we are really, really worried about is low blood pressure more than high blood pressure. High blood pressure, we cannot tolerate in patients with pregnancy. Oh, I take it back. There's no patience with women with pregnancy. Okay, these are the cardiovascular risk factors that come with hypertension. Again, it's a big list, so I give you some of them. JNC8 says that these are the risk factors for cardiovascular disease: age, diabetes, and estimated GFR of less than 60. We talk about this tomorrow. Okay, Mr. Smith has a BMI of 32. We know that around 25 would be better or less. He does not smoke and has no significant past medical history. So in this diagram, where does our Mr. Smith fit? Remember, everyone less than 140 over 90, except for those over 60 who do not have diabetes or CKD. Those will be 150 over 90. Our Mr. Smith was 60 some years old and he didn't have a major past medical history. For where does he still fit. Would you agree that he's on the left side? So he's 64. He does not have diabetes. He does not have CKD. So he will be here. 150 over 90 would be his goal. Step one, we made the diagnosis. We know the cutoff. We are comfortable. We are not going with New York Times. We know with JNC8 has told us 142 over 90 is hypertension. Okay. Now we want to know what are the causes. Is there a cause or it is all primary? We call it essential hypertension or primary hypertension. Is it all essential or primary or some causes, something has made us hypertensive? Foods and drugs are number one. There are two causes. One is foods and drugs. Another big list. Should I learn all of these? These are the foods and drugs that can give us hypertension. No, you don't need, and I don't know all of these, but I know some of them. These are the ones that you need to know. Steroids. Those who take steroids, they tend to have higher blood pressure. Sterogens, OCP, makes your blood pressure go up a little bit. NSAIDs, always in nephrology, for some reason, we all hate NSAIDs. NSAIDs bring up blood pressure. We should know about it very well. We should ask the patient that is hypertensive, do you take naproxen? Do you take Advil? Do you take ibuprofen? If they are taking it, we tell them not to take it. The fun thing is cocaine. Cocaine itself gives hypertension. Withdrawal also gives hypertension. No win situation with cocaine. The same is with smoking. Smoking increases blood pressure. Withdrawal increases blood pressure. So smoking and cocaine are very special. Nicotine and withdrawal and anabolic steroids. Those who get it for muscles and all those, they have a tendency for to have higher blood pressure and alcohol. That's why I tell you that office blood pressure might not be that great. That's why we rely on home blood pressure or ABPM. Because if it's just enough that the patient is a smoker, smokes his last cigarette in the car before coming to my clinic, 15 minutes later, he's in my clinic, they check the blood pressure, is through the roof. It might not be his real blood pressure, right? Should we go for another question? Let's do it. 57-year-old lady, preoperative physical exam for a total knee replacement procedure. Medical history is significant for osteoarthritis. Her only medication is over-the-counter ibuprofen, which she takes multiple times daily for pain relief. On physical exam, blood pressure is 152 over 90. Is it considered hypertension? It is, yes. And pulse rate is 64. BMI is on the higher side, 34. Severe osteoarthritis and all those. So creatinine is 1.2. Potassium is 5.1 on the higher side of normal. Urine dipstick has no blood or protein. Which of the following is the most appropriate next step in management of this patient's blood pressure? Start a low dose ACE inhibitor, begin low dose hydrochlorothiazide, discontinue ibuprofen, obtain a plasma aldosterone plasma renin ratio. What is this for? Why do I check D? To diagnose what? Renin and aldosterone. What? Kidney function for renin and aldo? High blood pressure, that's for sure. All of these would be to see if there is high blood pressure, but I am looking for a specific disease if I am checking renin and aldo. It can be used in many diseases, but we have, you and I, we have talked about a specific, more common disease that you need to check renin and aldosterone. And it was a buzzword for USMLE. There is, I give you the features, you give me the name. Serum potassium is low, hypokalemia, there is hypertension. So hypertension, hypokalemia, low renin, high aldosterone. Then you have these four things, you think of that disease. Let me give you another feature, make it easier. Metabolic alkalosis. Primary hyperaldosteronism. Primary hyperaldosteronism. Do you remember the adrenal gland was secreting aldosterone? Aldosterone increased sodium excretion, sodium absorption, potassium excretion. Hypertension, hypokalemia. Because aldosterone was secreting high, it was the primary disease. Aldosterone was high, but as a loop feedback, the renin was suppressed. So low renin, high aldosterone, hypokalemia, hypertension, metabolic alkalosis because of the impact of aldosterone on potassium hydrogen ATPase in intercalated cells of the collecting duct. I know that it is too much, but when you are going to go and review those cases, you will see what I was talking about. So, going back to this lady, she comes for pre-procedural labs. They see she has hypertension. What is the good thing for her to do? A, B, C, D. Should we go with stopping ibuprofen that gives her? We said that NSAIDs are among the medicines that increase blood pressure. So if the patient is taking NSAIDs, we just tell them to stop. Also, it is easier said than done. There's a reason why they're taking it. If they are in major pain, they don't listen to you. They are going to take it. But anyways, our best, I would say, advice to her would be to discontinue ibuprofen. Advil or ibuprofen is Mr. Smith. We say that he once in a while takes it after he plays golf. So once in a while, I think we might just go with it. Okay. So we said the causes of hypertension. We talked about a few foods and drugs that gives us hypertension. We know about them. We should stop them if somebody has hypertension. What about the second one? Some diseases give us hypertension. We need to think about those as well. Again, a big list. Should you memorize all of this? No. These four would be enough. Chronic kidney disease, this is very fun. Tomorrow I will talk about it. It's one of those special occasions when hypertension can be the cause of um, a CKD, or CKD can be the cause of hypertension. So hypertension can be the cause of chronic kidney disease or the consequence of chronic kidney disease. Okay, so when we see it, but that's an easy one to diagnose. We have serum creatinine, we know. Primary hyperaldosteronism, we talked about it right a few seconds ago. Renovascular hypertension is when I have renal artery stenosis. Think about the renal artery bringing blood to the kidney. So the blood is coming here. If I have a stenosis of my renal artery, there is not enough blood coming to the kidney. The kidney senses this as dehydration. It's not getting enough blood flow, right? It's dehydration. What does it do? It triggers the RAS, renin, angiotensin, aldosterone. Because remember, just something we need to know about it. RAS, we are always trying to block it. We think it's the cause of many of our troubles. But RAS in your body and my body is a mechanism of defense. We need to have it to survive. Today, I am having an accident on the road. I am bleeding. My blood pressure is coming down. What will keep me alive until you take me to the hospital? RAS. The blood pressure is coming down. Renin is secreted. Aldosterone, sympathetic nervous system. All of these are, what are they doing? They're trying to bring up my blood pressure, stay alive, having perfusion to my brain until I get to the hospital. So RAS is great. We need to have it. When we talk about RAS blockade, we think that here it is maladaptive. It should not be high, and it is high. Does that make sense? Like SIADH, it should not be high, the AVP or ADH, but it is high. Does that make sense? Very good. Okay. So in renovascular hypertension, the narrowing of the renal arteries, not enough blood going to the kidney, RAS is triggered. Renin, angiotensin, aldosterone, sympathetic nervous system. The blood pressure goes through the roof. And sleep apnea, for some mechanisms that are not very well known, if somebody has a sleep apnea, the blood pressure goes up. I always tell patients that if somebody makes you a diagnosis of sleep apnea for you, It's kind of a blessing in disguise. I know that it's a new diagnosis, new disease that you have, but it also tells you that if you take care of sleep apnea, your blood pressure might go away. Okay, again, another big list. You just remember that there are ways to diagnose these. You don't need really to memorize anything from this, but for apnea, obviously you check sleep study. Okay, Mr. Smith snores like a tractor. At his wife's insistence, he recently had a sleep study. He does not have sleep apnea, so treating his sleep disorder would not be an option for blood pressure. Okay, we talked about the diagnosis. We talked about two things that increase blood pressure, the causes. One was food and drugs. One was diseases. We talked about different diseases, including primary hyperaldosteronism that we all need to know, renal artery stenosis that we need to know. Okay, now it's time for management. How do we manage? Number one is not the medicine. Number one is how do we change our lifestyle? And lifestyle has two parts: physical activity, diet, right? The first part is lifestyle modification. I love this big table. I think everybody should know about it, even not the medical students. What it tells you here, and it is a very well done table. This is, first of all, in order. These are the modifications. Five things are here that in order, meaning that weight reduction is more important than DASH diet. This is more important than sodium reduction, more important than physical activity, more important than alcohol consumption. One, two, three, four, five. I like this. But having said that, you should be careful what their impact is. For example, on this side, you look at it, it tells you every 10 kilograms, every 20 pounds that you lose, your blood pressure will go down by 5 to 20 millimeter mercury. So it's not that you lose just 2 kilograms and your blood pressure will normalize. Just keep that in mind, the extent of it. But more importantly, what is DASH diet, guys? You guys are young, you need to know about DASH diet regardless of medical school. Yeah. Mhm. The three components, yeah. And its emphasis, the DASH diet, is on vegetables and fruits, right? It tells you DASH diet, and then we have modified DASH diet, low salt DASH diet, or whatever DASH diet. DASH diet is all about getting fruits and vegetables, healthy food that everybody talks about, right? Think about it. Have you noticed that DASH diet is above dietary sodium reduction? What does that tell you? Think about it. Whoever you go in the street and ask somebody, I have high blood pressure, they tell you, cut down on your salt. But here it tells you having a DASH diet is more important than low salt diet. What does that tell you about sodium and potassium? Sodium and potassium. What does that tell you? Do you think DASH diet has a lot of potassium in it? Fruits and vegetables, that avocado, tomato. Do you remember all those strawberries at the first thing, Bena? You remember that? That's how it works here. It tells you if you want to have good blood pressure, go up on potassium, cut down on your sodium. That's basically tells you. And if you corner me and tell me, Amir, I want to do only one of them. Should I cut down on the salt or go up on the potassium? What would be my answer based on this? Go up on potassium. You see, we call it banana therapy. You want to be healthy, get one banana a day, it brings down your blood pressure. Giving potassium brings down the blood pressure. Okay, that's why it is important. Again, don't go involved in these details. You read it for your personal interest, or these numbers. I don't remember all these numbers either, just the concept of it. These five you need to know, and you need to know, actually this has been a board question in the past. How much alcohol is uh, considered normal for men and women if you want to tell them to cut down on alcohol? Two per day for men, one for women. Okay. The rest of it is just for your personal interest. It's not for USML. It's not for anything. Just I put it here so you can go on it and just enjoy your life. We all need to know a good part of this. So Mr. Smith's BMI is 32. Says he loves drinking beer with his friends. Who doesn't? In the local pub almost every evening. 3 to 6, but God bless his heart. While having a cheeseburger or fried chicken. He loves playing golf, but he's not so enthusiastic about other physical activities. In order to manage his blood pressure, you ask him to change his lifestyle, reduce alcohol, 6 a day is obviously about, okay? Salt intake, try to lose weight through increasing his physical activities, as well as adopting a healthy diet with a lot of vegetables and less fat. If you think about it, the ratio of potassium to sodium is more important than the potassium alone or sodium alone, right? If you think about it, potassium going up, sodium going down. This number, the higher it is, the better it would be. Okay. So we talked about the first part of clinical approach. You see, we went through a lot until we get to the medicine. Don't start. You have high blood pressure, amlodipine 5. Everybody can do that, right? Go through all these steps when you see a patient with hypertension. Lifestyle modification has two arms: physical activity, diet. Now we go to medicines. Medicines, again, I don't know all these names. You don't need to know them. On each of them, you need to know some. The point I want to know is that we have different types: thiazide diuretics, beta blockers, whatever, and you know about them during your kidney course and cardiovascular course. What is important is that sometimes they combine them: beta blockers and diuretics, ARBs and diuretics, for example. They work on different aspects. You don't need to know them. It's just for your information. 2 months later, Mr. Smith comes for a second visit, accompanied by his wife. We had given him some advice on lifestyle modification. He informs you that he has had a significant change in his lifestyle, as you had advised him. He has brought you a log of his blood pressures at home, which shows an average of 152/96. Should we treat this patient or should we leave him alone? Now it's time to treat this patient medically. I tailoring hypertension. So we have all those medicines that I showed you. Which one should I pick? This has been the focus of so many studies. Here is the thing. This is an old table, but it tells you something. It tells you on this left side, on the y-axis kind of thing. If you have heart failure, all of these are good except for calcium channel blocker. If it is after MI, these three are really good. Coronary heart disease, these four are good. And you see, concept is, look at here. ACE inhibitors are good for everything. That's why nephrologists like me, we typically start a patient on ACE inhibitor unless there is a reason, right? Because it's pretty much good for everything. So if you look at JNC8, so far I had shown you only the part that was the diagnosis. We had looked at the whole thing until here. Now they say for all the patients on this side who have CKD or diabetes, always start ACE or ARB. For the other ones, they say if black or non-black, do this. The bottom line, to make it easy, I tell you this. If I have CKD or diabetes, ACE inhibitors are the way to go. If not, thiazides would be good. And in the past, they said again, black, non-black. We said that race is not a biology construct. Next hour, we'll talk about it. And I put 130 over 80 just to tell you, nephrologists are not big believers in 140 over 90. We tend to treat our patients for 130 over 80. And if they have proteinuria, we actually go to 125 over 75. The point is that 140 over 90, we think that it is a little bit too liberal. Please. Yes, they definitely do, and that's why that has been actually the thinking behind this to make it black and non-black. Traditionally, I can tell you, based on the studies and my personal experience, those who are blacks tend to respond very well to thiazide diuretics. For whatever reason, they have a tendency for higher salt in their body, right? So thiazide diuretics are the way to go unless they have CKD or diabetes. In that case, I go over. Again, anything you pick would be good. But if you look very carefully to this diagram, there is one of the families that you see is absent. Look at this. It tells you you can take this or this or this or this, but that one is not there. They are out of favor these days. Which ones are they? Beta blockers. Beta blockers are not the first line of therapy at this point. If you see it in a question, there are different options. Beta blocker is not the one you go for. Thiazide diuretics, everyone, ACE or ARB for the. So you Okay, we have 5 minutes. You prescribe a diuretic for Mr. Smith, hydrocortisone 12.5, and ask him to maintain his new healthy lifestyle. What is resistant hypertension? And you know, resistant, everybody knows what resistant means, but there is a specific definition for it. You should have three medicines at their optimal dose, one of them a diuretic. When you have these three, one of them is a diuretic. They're at optimal dose, not the homeopathic dose, real dose. Yet the hypertension is not well controlled. We call it resistant hypertension. Okay, this would be resistant hypertension. So what are again a big deal? Do I know all of these? No. Do you need to know? No. Which ones do you know? Excess sodium intake, NSAIDs, and non-adherence. I can give you all the medicines in the world. Unless you are on a low salt diet, your blood pressure will not be well controlled. Keep that in mind. Another aspect that comes in USMLE questions, I thought I would push it for you here, is acute severe hypertension. The hypertension that we talked about over the years will affect us. But this one is acutely, they come to the emergency department. There are two types. One is hypertensive emergency, hypertensive urgency. The difference is the end organ damage. In emergency, there is an end organ damage that is happening or has happened. Urgency, just a high blood pressure, no end organ damage. For example, here it is hypertensive emergency. That's a high blood pressure of 180 over 120 and higher, impending or progressive target organ dysfunction. It can be acute MI, it can be encephalopathy, it can be pulmonary edema, it can be acute kidney injury. I don't know if acute kidney injury is not here. These are some examples. So when you have these plus high blood pressure is an emergency. What's the difference? Why do I talk about it? It tells you this patient needs to be admitted and needs intravenous medicine to bring down the blood pressure. It's not that you give them 5 milligrams of amlodipine, have a good day, right? Admission to the hospital is needed. And these are all the IV medicines that are, this is just for your reference. Obviously, you don't learn them. I put the three that most people use, labetalol, hydralazine, and nicardipine, but it depends on the hospitals and their resources. Hypertension urgency is the other one. This is basically somebody who has been hypertensive and has stopped taking their medicines. Their blood pressure goes through the roof, but there is no end organ damage. All you do is to restart their medicines. No admission to the hospital is needed. Remember what I told you about hyponatremia and headache? I told you in that one is a major emergency. Here is nothing. Hy- Headache is not emergency. Bleeding in head is. Beyond lifestyle, I just left it for you to learn about it for your patients. You know, there are younger patients, you need to be empathetic and all those. I think you need to know about it a little bit. I don't expect you to read all these details, but take a look at them and see how you feel about it. How do you anticipate adherence problems for younger people? If you are young, you are more likely not to take your medicines. Individualize the regimen, and then if you have exam, your blood pressure goes up. Thank you so very much. What time is it? 8:55. 9:05, we start the second session. Thank you.